Here's something that might surprise you. There's a traditional Pacific plant that produces anxiolytic effects comparable to low-dose benzodiazepines, but with a lower dependence liability. Now, I want to be clear from the start, this is not me advocating for everyone to start drinking Kava, but understanding its pharmacology tells us something important about how people self-manage anxiety. Kava's active compounds, called kavalactones, do something quite clever. Just like benzodiazepines, Kava works as a positive allosteric modulator at GABA-A receptors. Think of it this way, benzos and Kava do not press the accelerator pedal directly. They both adjust the sensitivity of that pedal. The result, you get anxiolytic effects, muscle relaxation, and mild sedation, but without the same respiratory depression risk or the dramatic dependency profile we see with other drugs, such as barbiturates. Here's what this means for you. The clinical picture looks remarkably similar. Reduced somatic tension, calmer affect, improved sleep onset, but the safety margin is wider, particularly regarding respiratory function. That said, and this is crucial, Kava still potentiates other CNS depressants. Combining it with alcohol, benzodiazepines, or opioids is genuinely dangerous. Now let's talk about the elephant in the room, hepatotoxicity. The literature shows rare but real cases of liver injury. And here's where preparation matters enormously. Traditional aqueous preparations, the way Pacific Islanders have consumed Kava for centuries, appear much safer than concentrated ethanolic or acetonic extracts. The mechanism likely involves mitochondrial toxicity, glutathione depletion, and CYP450 inhibition, particularly when you're dealing with high-dose extracts or non-noble cultivars. From an addiction medicine perspective, what's fascinating is the dependence profile. Physical dependence is minimal. Psychological dependence can develop in daily heavy users, particularly those with trauma avoidance patterns. But we're not seeing the withdrawal seizures, the autonomic instability, or the severe rebound anxiety that characterizes things like alcohol withdrawal. The reinforcing properties appear to come from mild CB1 receptor activity and dopamine modulation, but it's subtle. One more critical point. There's confusion about Kava and serotonin syndrome because some sources mention monoamine oxidase inhibitor activity. Let me clarify this definitively. Kava produces weak, reversible inhibition of monoamine oxidase B, not monoamine oxidase A. Monoamine oxidase A metabolizes serotonin. Despite decades of use and common co-administration with SSRIs and SNRIs, there are 0 documented cases of Kava-induced serotonin syndrome. The risk lies elsewhere: sedation with CNS depressants, hepatotoxicity with extracts, and cognitive impairment at higher doses. So here's your takeaway. Kava has similar sedative effects to benzodiazepines and is commonly used within the Pacific Islander community. But it is not risk-free. If you're considering it, stick with traditional preparations, avoid alcohol and other sedatives completely, and if you have any liver disease or take hepatotoxic medications, it's off the table. As always, this is a conversation to have with your physician, not a decision based on a podcast. I'm Dr. Fergal Armstrong, and this has been Cracking Addiction.